Hi, good afternoon, and welcome to the CDC's Hemoglobinopathies webinar series. I'm Christy Kenny, sitting in for Shay Pope from the Division of Blood Disorders, and I will be serving as today's moderator. As the conference leader, I have muted all the conference lines to eliminate background noise. After the presentation, we will allow questions, and you will have to press *6 to individually unmute your line at the time. If you have a question, you can electronically raise your hand by accessing the Q&A tab on the menu bar of your webinar screen and click on the hand icon in the upper right-hand corner. This will display your name to the moderator. I will call on participants as their names are displayed. You can raise your hand during the presentation, but we will wait until the discussion period to address those comments. Also, this session is being recorded. Today's topic is hydroxyurea, efficacy and effectiveness in children with sickle cell anemia. Dr. Winfred C. Wang is a member in the Department of Hematology at St. Jude's Children's Research Hospital in Memphis, Tennessee. He received his BA in chemistry at the University of California in Berkeley and his doctoral degree in medicine at the University of Chicago. Then he completed his residency in pediatrics at Montefiore Hospital and Medical Center in Bronx, New York, followed by a fellowship in pediatric hematology at the University of California Medical Center in San Francisco. He joined St. Jude's in 1979 as an assistant member where his focus was on pediatric hematology. He was chief of the Division of Hematology from 1996 to 2004. Dr. Wang provides clinical care to children with hematological disorders in both the inpatient and outpatient setting, and mentorship related to clinical care and research for junior faculty members. Dr. Wang was the director of the St. Jude Comprehensive Sickle Cell Center, one of the 10 federally funded centers in the United States from 2003 to 2008. He has published more than 170 original articles and 30 chapters and reviews. He served as the chair of the Baby Hug Steering Committee, which now is in the follow-up extension phase of the protocol. Dr. Wang also served as the national PI for the hydroxyurea magnesium, or CHAMPS trial, for patients with hemoglobin SC disease. Dr. Wang is a member of the American Society of Hematology, the American Society of Pediatric Hematology Oncology, the International Society of Hematology, and the Just Society. Dr. Wang's research interests are sickle cell disease and other hemoglobinopathies, aplastic anemia, and other disorders of bone marrow failure. And now I'd like to turn the webinar over to our presenter, Dr. Wang. Please unmute your line by pressing *6 at this time to address the audience. Hello, Dr. Wang? You can unmute your phone by pressing *6.
Thank you very much for that lengthy introduction, and I appreciate the invitation from the CDC to give this webinar. Can you hear me okay?
Yes, we can. Thank you.
Okay. So I'll be talking about efficacy and effectiveness, and this is the outline of the material that I plan to cover. Some background about hydroxyurea, discussion of the Baby Hug main study, which was published in 2011, some newer data on toxicity as a result of that Baby Hug study. I'll make some comments about hydroxyurea and organ function, consider some issues about hydroxyurea and effectiveness, and also touch on some current controversial issues. So efficacy is defined as the extent to which a specific intervention produces a beneficial result under ideal circumstances. And so here we're usually talking about research conditions. Effectiveness refers to the extent to which a treatment achieves its intended purpose and is related to real-world conditions. A little bit about hydroxyurea, which is a very simple molecule as indicated over here. It was originally developed as an anti-neoplastic agent in the 1960s, but then was discovered to be an anti-sickling agent in the 1980s, and I'll describe that in a little more detail in a minute. It has multiple mechanisms of action, but it's primarily thought to work by inhibiting ribonucleotide reductase. And the laboratory and clinical efficacy from hydroxyurea are mostly related to hemoglobin F induction to protective levels in the sickle cell. And shown here is a typical image of a sickle cell patient's peripheral blood smear before starting hydroxyurea and then after hydroxyurea has been given for a while, and you can see that there are differences in terms of fewer sickled forms and more target cells. So in 1984, Ora Platt and a number of very prominent authors published an article in the Journal of Clinical Investigation describing two patients with hemoglobin SS, these are both adults, treated with hydroxyurea at doses of 50 milligrams per kilogram per day by mouth for 5-day increments. And this was associated with increases in fetal reticulocytes within 48 to 72 hours, and also a marked increase in F cells. Hemoglobin F increased from 7.9% to 12% in patient 1 and 5.3% to 7.4% in patient 2. So this sort of proof principle article raised many questions, including the following. What is the precise mechanism of action of hydroxyurea? What is its optimal dosage and schedule? What are the long-term and short-term benefits and risks? And what proportion of patients will respond to the drug? And as you'll see from this talk as I go along, none of these questions have been fully answered except perhaps the short-term benefits and risks. From Russell Ware's How I Treat article in Blood of 2010, some of the mechanisms of action of hydroxyurea are illustrated here, and they include the increase in fetal hemoglobin, which is thought to occur through altered erythroid kinetics, the decrease in neutrophils and reticulocytes, which improves blood flow rheology. There's also decreased adhesiveness of those cells to the vascular endothelium. There's decreased hemolysis and increased nitric oxide release. There have been 3 major multi-center U.S. trials of hydroxyurea in the United States and a number in Europe. The most significant report was the results of the multi-center study of hydroxyurea, or the MSH trial, which was performed in adults with severe sickle cell anemia and was a phase 3 trial comparing hydroxyurea to placebo in a double-blind manner. This study was led by Sam Sharash and was published in the New England Journal in 1995, and it reported that pain, acute chest syndrome, hospitalization, and transfusion were all dramatically reduced in the hydroxyurea arm. The HUG-Kids trial in children 5 to 15 years of age was a phase 1 and 2 trial that looked at hematologic response and found that it was similar to that seen in the adult trial, and also noted that there was a relative lack of toxicity in hydroxyurea with dosing up to 30 milligrams per kilogram per day. The Hughes-Soft trial was a relatively small prospective phase 1 and 2 trial in very young children, 6 to 24 months of age, with sickle cell anemia. And this study showed that, again, there was hematologic improvement and also that it was feasible to give hydroxyurea to this very young population. It also suggested that there was some improvement in spleen function based on spleen scan results. And this actually served as the pilot trial for the baby hug study, which was a phase 3 trial that was published 2 years ago and involved randomization of 90-some patients about 180 patients to receive either hydroxyurea or placebo, again in a double-blind manner for 2 years. The primary goal of the baby hug study was to determine whether hydroxyurea can prevent or reduce chronic organ damage to the spleen and kidneys in very young children with sickle cell anemia. But there were a number of important secondary goals, and these included investigation of safety, determination of hematologic effects and effects on other measures of organ function, and examination of the effects on adverse events. So in this and the next figure, the curves shown in blue are for placebo, the placebo group, and in red are shown the data for the hydroxyurea group. And in measurement of the cumulative incidence of these adverse events over the 2-year course of the randomized trial, it was found that the hydroxyurea arm patients had markedly less acute chest syndrome, pain, dactylitis, and transfusions. All of those were statistically significant at a p-value of less than 0.05. Hematologic changes were also seen, and hemoglobin, MCV, and hemoglobin F levels were all statistically significantly higher in the hydroxyurea group, and neutrophil count and absolute retic count were also lower in the hydroxyurea group. And when hematologic toxicities were examined, the only one that was significant was the occurrence of mild to moderate neutropenia with absolute neutrophil counts in the 500 to 1250 range. This was seen much more frequently in hydroxyurea than in placebo patients, but there were no differences in severe neutropenia, in thrombocytopenia, or severe anemia in the two groups. And in some additional information that was published last year, also from the baby hug study and reported by Courtney Thornburg et al., it was in further analysis of these data, it was shown that even in subjects who were totally asymptomatic at the time of enrollment into the baby hug study, hydroxyurea produced decreased amounts of dactylitis, hospitalization, transfusions, and episodes of acute chest syndrome. Also, hydroxyurea was not associated with increased splenic sequestration. It was not associated with increased risk of bacteremia or serious infection. And actually, hydroxyurea was associated with at least numerically fewer infections for unexplained reasons. And these included a statistically significant difference in gastrointestinal infections. So our overall conclusions from the baby hug study were that hydroxyurea does not prevent splenic or renal dysfunction based on primary endpoints, but there were differences favoring hydroxyurea seen for several secondary endpoints, and I'll describe some of these in a few minutes. Hydroxyurea does not have significant toxicity other than moderate transient neutropenia. The hematologic effects of hydroxyurea may lead to a more favorable prognosis. For example, increased hemoglobin F would be expected to be associated with decreased pain, acute chest syndrome, and mortality based on data from the cooperative study of sickle cell disease. And finally, hydroxyurea in this age group decreases the incidence of pain and dactylitis with p-values less than 0.01, and probably acute chest syndrome, transfusions, and hospitalizations, all of which had p-values between 0.01 and 0.05. So let me go on to talk about some of the toxicity considerations associated with hydroxyurea, because some of these were addressed specifically in the baby hug study. These include measures of immune function, genotoxicity, and growth, and in addition, a number of genetic modifiers were looked at in the course of baby hug. I'll say a few words about spermatogenesis and pregnancy, and describe the one case we had of overdose of hydroxyurea. So data from the immunology analysis from baby hug were presented at the ASH meeting last year by Jim Casella and Howard Letterman. It's known that sickle cell disease is associated with a marked susceptibility to encapsulated bacterial infection, particularly from pneumococcus. And it's also known that hydroxyurea inhibits ribonucleotide reductase and DNA synthesis. So it was postulated that hydroxyurea might inhibit immunologic maturation and possibly responses to vaccines. So in the baby hug study, the following immunologic evaluations were performed. T-cell subsets were measured at entry into the study when patients were 24 months old and at exit. Pneumococcal antibody levels for two particular pneumococcal serotypes were measured at entry before Pneumovax at 24 months of age, 2 to 8 weeks after Pneumovax was administered, and at exit. And then antibodies to measles, mumps, and rubella in patients who were enrolled before they received their MMR shot were measured 2 to 10 weeks after the vaccination, at age 24 months, and at exit. So the immunology studies showed, with regard to the lymphocyte populations, that the hydroxyurea group had lower absolute lymphocyte counts, CD4 T cells, and memory CD4 and CD8 T cells. But the percentages of these particular lymphocyte subsets and their absolute numbers were actually either greater than or similar to that seen in healthy controls. So these data suggest that CD4 T cells and memory T cells should be enumerated with further studies. But it can be postulated that in sickle cell disease, because lymphocytes are increased compared to lymphocytes in controls of the same age, that perhaps having decreased lymphocyte counts may actually be a good thing, because it could reduce inflammation and be associated with some clinical benefit. In terms of the antibody responses, those for measles seem to be delayed by about 1 to 2 months in the hydroxyurea group compared to the placebo group. But the antibody levels for MMR as a whole were normal by age 24 months and at exit from the study, which on average was at about 3 years. I should also mention that there were no differences in the antibody responses to the pneumococcal serotypes at entry or exit from the study between the hydroxyurea and the placebo groups. So it can be concluded that hydroxyurea may have some effect on vaccinations that are T-dependent, included in MMR, but not on those that are T-independent, as in Pneumovax. And the overall conclusions from the immunologic data so far are that no biologically important immunodeficiency seems to be associated with hydroxyurea, and as I've mentioned, there is no increase in significant infection, and therefore vaccination practice should not be changed. So we also looked at genotoxicity as part of the hydroxyurea study, and this has been reported by Pat McGann in Pediatric Blood and Cancer last year. So genotoxicity or mutagenesis was looked at because there have been long-term safety concerns for hydroxyurea postulated based on its mechanism of action, which is inhibition of ribonucleotide reductase, and based on reports of in vitro and in vivo genotoxicity assays, mostly using very large doses of hydroxyurea in animal models and published going back into the 1960s. There is no truly accurate in vitro measure of drug-related carcinogenicity, so what we're reporting are really surrogate markers of genotoxicity. These were collected before randomization into the baby hug trial and at exit, and involved 167 subjects followed for 374 patient years. And the data are shown here, but in summary, there were multiple assays used for the measurement of acquired genomic damage, but as I said, all these are surrogates. Chromosome breaks were increased between entry and exit, but this took place for both the hydroxyurea and the placebo group and was not different between the two. Chromatid breaks did not change with age and were not different between hydroxyurea and placebo groups. VDJ immunoglobulin receptor recombination or illegitimate recombination events at baseline and exit also were no different between the hydroxyurea and placebo groups, and micronucleated early reticulocytes, another measure of genotoxicity, were not different between hydroxyurea and placebo. So the bottom line here is that there was no evidence for mutagenesis in the baby hug trial. Having said that, I want to just mention some information about the risk of malignancy associated with hydroxyurea, since this has frequently been a major concern of both providers and patients. And really, the data are hard to analyze because the incidence of malignancy in sickle cell disease is unknown. The best information we have is from the International Association of Sickle Cell Nurses and Physicians Assistants that published a retrospective analysis or tabulation, really, of malignancies occurring in 16,600 patients and noted that there were 52 cases. However, only 3 of those cases were in patients who were receiving hydroxyurea at the time. If you compile all the case reports of malignancy in sickle cell patients on hydroxyurea, there were 11 with leukemia, 1 with Hodgkin's lymphoma, and 3 solid tumors that have been reported. However, nobody really knows what the denominator is for these cases. And a very rough guess would be that there are more than 50,000 years of exposure to hydroxyurea now, and this would be worldwide exposure. And so if you do a very rough calculation, that comes out to be 1 case per 3,500 person years of exposure. Slightly more definitive data were reported from the multi-center study of hydroxyurea in their longer-term follow-up, and they found that 3 malignancies occurred in 299 patients, or in about 1% of patients, and the risk seemed to be roughly 1 in 1,000 person years. So this might compare to the overall risk for malignancy in adults, which I've been told is roughly 4.6 per 1,000 person years. So I think the overall conclusion from these limited data is that there is no evidence for increased risk of malignancy in association with hydroxyurea. So getting back to the baby hug study, we also looked at genetic modifiers of sickle cell anemia using baby hug data, and this was published with the first author being Vivian Sheehan in the American Journal of Hematology earlier this year. A few words about genetic modifiers. It's known that hemoglobin SS is very heterogeneous in its phenotypic expression. And in a number of reports, genetic polymorphisms have been reported to have an influence on the sickle cell anemia phenotype. And these genetic polymorphisms have involved alpha thalassemia trait, beta globin haplotypes, hemoglobin F modifiers, including the XMML gene, the BCL11A, and the HBS1L MIB genes. Also, UGT1A1, which is associated with glucuronal transferase, has polymorphisms which have been reported to be associated with the effectiveness of bilirubin conjugation, which is the function of that enzyme. And also G6PD deficiency has been reported to have various effects on sickle cell phenotype. However, the effects of these genetic modifiers in patients receiving hydroxyurea are basically unknown, and so this was a secondary objective in the baby hug trial. And I won't go through all of these results, but I'll mention that alpha thalassemia was associated, and this is both single and 2-gene alpha thalassemia, was associated with decreased MCVs at entry and at exit in the placebo group, but not at exit in the hydroxyurea group. These polymorphisms, which influence fetal hemoglobin levels, if they were favorable polymorphisms, were associated with hemoglobin F increases at entry, but at exit, they did not make a difference in the patients that had been treated with hydroxyurea. And overall, the hydroxyurea responses seem to supersede the effects of alpha thalassemia and hemoglobin F modifiers, suggesting that testing for genetic modifiers would not be particularly helpful in deciding whether or not to treat a patient with hydroxyurea. And then growth has also been a concern in the treatment of patients with hydroxyurea, both because there have been a little bit of animal data suggesting that growth is impeded by hydroxyurea, and there was the possibility that growth might be enhanced by hydroxyurea. So anthropometric data for height, weight, and head circumference converted to z-scores and utilizing World Health Organization standards was evaluated in the course of the baby hug study. And here the finding was that hydroxyurea and placebo were no different for height and weight, and in both groups slightly exceeded the what were considered normal values by WHO standards. And the curves are shown here. And just a few words about spermatogenesis, which is not based on anything from the baby hug trial. It's known that it's been known since 1989 that decreased sperm counts are a complication of sickle cell disease. And in 2000, there was a case report of reversible azoospermia in a patient who was treated with hydroxyurea. The largest study published to date involved 44 men who were analyzed in a French study and found to have abnormal sperm parameters in 91% of the cases, and that's without any treatment. During treatment of 5 of these patients, there were further decreases in sperm concentration and count, and then after treatment, there was some partial recovery. But basically, although there were a bit more data that were presented at last year's ASH meeting, a lot more data is needed on sperm alterations in association with hydroxyurea to see whether they exist and how significant they are, and to see whether cryopreservation of sperm might be indicated in patients who are in male adult patients who are being treated with hydroxyurea. With regard to pregnancy, in the MSH follow-up of close to 300 subjects, there were 94 pregnancies that occurred, and these led to 55 live births, and no teratogenicity was seen in these cases. And in the course of baby hug, we did have one accidental hydroxyurea overdose in which a 2-year-old ingested a month's supply of study drug. This is liquid drug that obviously tasted pretty good. And this amounted to a dose of 612 milligrams per kilogram. The patient was brought to the emergency room. Emesis could not be induced. And 4 hours after ingestion, the patient had a serum hydroxyurea level of 7,700 micromolar, with the therapeutic range being 200 to 500 micromolar. So despite this massive hydroxyurea ingestion, the only toxicity that occurred in follow-up over the course of the next month was that the neutrophil count fell from 2,500 to 1,600 on day 3. But by day 7, there was complete recovery of the blood counts. This is not to say that it's okay to take this huge dose of hydroxyurea, but at least there were not horrendous complications from that. So a little bit about hydroxyurea and organ function, and I'm not going to present a whole lot of data here, but I'll summarize data in a minute. In the baby hug trial, we did find that some secondary measures of spleen function, including quantitation of Howell-Jolly bodies and pit cells, and quantitative measurement of the spleen to liver nuclear count ratios, all seem to be improved or or that is, they seem to increase to a lesser amount on hydroxyurea compared to placebo, with p-values less than 0.05. And in a recent report by my colleague Jeremy Estep, published in the British Journal of Hematology, the effect of hydroxyurea on retinopathy was examined. And of 123 children with hemoglobin SS seen at St. Jude, 10.6% developed retinopathy on their annual or biannual examinations. And it was noted that there's kind of a threshold level of 15% hemoglobin F, above which below which patients were 7 times more likely to develop retinopathy. And among the children that were treated with hydroxyurea, those who had retinopathy were the ones who had poor responses in terms of increases in fetal hemoglobin. So all this suggested that the induction of fetal hemoglobin from hydroxyurea may help prevent retinopathy. And so in examining organ function associated with hydroxyurea and looking at the literature as a whole, just wanted to make a few comments. So in secondary stroke prevention, the recent SWITCH trial has shown that hydroxyurea is probably not as good as chronic transfusion in preventing restroke, and this was published in Blood in 2012. As far as primary stroke prevention in patients who have abnormal TCD velocities, there have been multiple single institution reports that indicate that hydroxyurea lowers TCD velocities. And this is being analyzed in the randomized TWITCH trial, also led by Russell Ware, which is now ongoing. There is a little bit of evidence that hydroxyurea could improve neuropsych performance, and in so far unpublished data from the baby hug trial, it appears that there were fewer patients who had a lower full-scale IQ below 85 at exit, although the average full-scale IQs were similar in the hydroxyurea and placebo groups. And there are some reports on the effects of hydroxyurea on silent cerebral infarcts, suggesting that there is some benefit in terms of reducing the frequency of silent infarcts, but there have been no definitive studies on this to date. I mentioned that in the baby hug study, there were no significant differences in the primary endpoint of spleen function by qualitative evaluation of spleen scans, and that there were some there were better findings on hydroxyurea for some of these other secondary biomarkers for spleen function based on the baby hug study. For renal function, the primary endpoint of GFR measured by DTPA clearance was not different between the two groups in the baby hug study, but again, in secondary endpoints, there was some evidence that hydroxyurea was associated with better results for urine concentration and decreased renal volumes in that arm. And I mentioned the data on retinopathy just now. So what about hydroxyurea and effectiveness? There are barriers to hydroxyurea use, which have been reported by providers in a survey by Amanda Brandow, published 3 years ago, based on responses of members of ASFO. And these responders indicated that the main issues preventing hydroxyurea use were patient compliance with taking medication, patient compliance with blood tests, lack of contraception in females, patients' anticipation of side effects, or the patients being too young. So actually, the providers sort of placed all the barriers on the patients. And on the other hand, a study published this year by Suzette Oyeku in PBC looked at the parents' reports of barriers to hydroxyurea use, and in examining the response of parents of 5 to 17-year-olds, it was noted that 38% were currently taking hydroxyurea, and factors associated with hydroxyurea use were parental knowledge about its therapeutic effects, and factors associated with factors not influencing hydroxyurea use included the parent's educational level and the travel time to see a hematology provider. Reasons for those patients who were not taking hydroxyurea for their not taking the drug were that it was not offered by the provider, that the child was not symptomatic enough, or there were concerns about potential side effects. And a little bit about mortality, and you'll be hearing much more about this in next month's webinars led by Charles Quinn. There have been 3 trials that have been, or 3 reports, I should say, of retrospective data that indicate that mortality seems to be lower in patients who are receiving hydroxyurea, even though they are intrinsically more sick than patients who have not been treated with hydroxyurea. And these involve 2 adult long-term follow-up retrospective analyses and 1 pediatric analysis. And again, I think you'll hear more about this from Charles next month. And the global considerations with hydroxyurea include a number of things, but eventually this is a potential population in which effectiveness may be able to be assessed. And there is now a global sickle cell disease network that is led by Isaac Odame from Sick Kids in Toronto, which has the goals of determining the most effective and efficient ways to treat sickle cell disease in low-income settings. And there's currently a follow-up study of Baby Hug, which is going on. There was actually an initial follow-up study which lasted until the end of 2011, and the current follow-up study, or follow-up study 2, includes additional CNS, renal, pulmonary, splenic, and abdominal evaluations. And this study, which began in January of last year, is funded until December of 2016, except for those periods when the U.S. government shuts down. And at that time, patients will be 13 years old on average, and so it will be very important to see what the long-term benefits and toxicities are at that point, and to continue to follow those patients. And so finally, I want to just talk about a couple of controversial issues. One is dosing of hydroxyurea and whether it should be escalated to maximum tolerated dose. In Russell Ware's review article on How I Treat, he noted in this table that patients in North America that have been reported generally have been treated to maximum tolerated dose, whereas patients in Europe in general have been treated with a fixed dose of 20 milligrams per kilogram of hydroxyurea per day. And he also noted that fetal hemoglobin levels seem to be higher in those treated to maximum tolerated dose Here they average about 22, and this is compared to an average of perhaps 15 in those on fixed dose. Skip this slide. But this raises questions about the differences in dosing approach in Europe and North America, and it raises questions of what the approach should be in treating large numbers of patients in both sub-Saharan Africa and India. We are looking at retrospective data from the Baby Hug Follow-Up Study 1, which may prove to be useful in analyzing effects of escalating to MDD, and in a local analysis at St. Jude in a small number of patients who were started on hydroxyurea and escalated to MTD. There was a suggestion that there is an advantage in terms of MCV levels and hemoglobin F levels of that escalation, and this will be presented in a poster at this year's ASH meeting. And so the final question I have is, should hydroxyurea be given to all, or at least offered to all, hemoglobin SS patients? And this is my subjective view of this very important question. So the considerations for or against hydroxyurea and the summation of whether they represent an advantage for hydroxyurea are shown in this table. And in terms of clinical effect, as mentioned several times, hydroxyurea does yield lower frequencies of pain, dactylitis, acute chest syndrome, and hospitalization. But there may be a population of perhaps 10 to 30% in whom hydroxyurea is not effective. But overall, because of its clinical effect, in the large majority of the population, this is a major advantage for hydroxyurea. In terms of toxicity, hydroxyurea has only been clearly shown to be associated with mild to moderate neutropenia, but it's possible that there are some long-term effects that we are not aware of, and there does seem to be a likelihood of some effect on spermatogenesis. So, of course, any toxicity would be a disadvantage for hydroxyurea. In terms of prognosis, the data that's now being reported on decreased mortality associated with hydroxyurea, in my mind, is a major advantage for giving this drug. And as I've mentioned, there is some evidence that there is some improvement in organ function, although I don't think this will be a major advantage in the future. And in prognosis, again, there could be risks that we don't know about from hydroxyurea at this point. But overall, I see this as an advantage for giving this drug. In terms of quality of life, hydroxyurea is associated with less pain, hospitalization, and ED visits, and therefore is advantageous. But a disadvantage is that it requires greater numbers of clinic visits for monitoring, and of course it means taking a daily medication. So perhaps this is even in terms of hydroxyurea versus no hydroxyurea. And in terms of cost, some recent data that we published from the Baby Hug study, actually which appeared in Pediatrics a couple of months ago, there is an advantage for hydroxyurea in that there is about a $2,000 to $3,000 savings per year in giving hydroxyurea because of less frequent hospitalizations and ED visits, which offsets the increased cost of clinic visits and increased laboratory tests and the cost of hydroxyurea itself. And so my bottom line to all of this is that, there is an advantage overall for hydroxyurea that's enough to warrant it being offered to all hemoglobin SS patients. And with that, I'll stop, and I'd like to thank you for your attention, and especially thank our baby hug kids who've contributed lots of information to this presentation. Thank you very much.
Thank you so much, Dr. Wang. That was a great presentation. We will now open our lines for questions. Please remember to unmute your phones individually by pressing *6. If you have a question, you can raise your hand electronically, and your names will be called in the order received. We have this line until 3 p.m., and we will end question and answer portion at that time. Okay, it looks like we have a question.
Hello, this is Dr. Nadia Ewing. I have a question for Dr. Wang. In one situation, one of my adolescent patients who had great MCVs and hemoglobin F levels and so forth started dropping his MCVs, but assured me that he was really taking hydroxyurea, and so did his parents. I am still not convinced that he was, but it would have been nice to be able to draw an hydroxyurea level, and I'm wondering, are these tests commercially available, and if not, where would one be able to obtain them?
Yes, unfortunately, they are not commercially available. There are a couple of labs that have done hydroxyurea analyses, but actually concerns about their reliability. Those are commercial labs. And Dr. Ware's lab has published on hydroxyurea pharmacokinetics and pharmacogenetics. But he has moved to Cincinnati, and I'm not sure whether he's still doing that, but you could easily contact him and ask if his lab still does do hydroxyurea levels. You could send me an email, and I can look up the contacts for possible commercial labs.
Great.
And the other comment I was going to make is that there may be other ways to assess hydroxyurea adherence, and we've actually been looking at that very issue in our patient population, and actually looking at a subset of patients that have been on hydroxyurea for a long period of time. And one of our patients seems to fit almost exactly the description that you've just given, in that he's an older teenager who's been on hydroxyurea for about 15 years and who swears that he's taking it every day, but who's had falling off of his fetal hemoglobin and MCV and hemoglobin levels and intermittent increases in his neutrophil counts. And when we analyze the amount of hydroxyurea that's been prescribed for him, and he gets it all through our local hospital pharmacy, we find that he's only received hydroxyurea about half as much as he should have if he's been taking all his pills. And this is despite reassurances that he has been taking it. So that, of course, raises credibility questions and makes us think that his drop-off in counts really is related to his adherence.
Right, which is my suspicion for my patient as well, but I just, wanted to really give him the benefit of the doubt, because I haven't seen any of that in any of the other young people that I take care of before. The other mention is that in some cases I've seen if the hydroxyurea level, if I increase the hydroxyurea more than perhaps I should, I also notice decrease in platelet counts. decrease in platelet counts, and I'm wondering if that is a described toxicity for hydroxyurea in patients with sickle cell anemia. I didn't see that in your slides.
Correct. I did show that in one of the 6 curves of hematologic change, there appears to be a lower platelet counts, but that I didn't say anything about that because it wasn't quite statistically significant.
Okay.
We did not see severe toxicity from the original baby hug study. I think there was one patient in follow-up study 1, I believe, that had a platelet count that dropped to less than 10,000 and then recovered, and we think that that patient had ITP.
Okay.
But there have been some reports of significant thrombocytopenia, which is often defined as a platelet count less than 80,000 in patients on hydroxyurea, but they're actually quite rare compared to neutropenia.
Right. Okay. Well, thank you very much. This is very helpful.
You're welcome.
All right. Is Tricia Wong? She has a question.
My question was whether the risk-benefit ratio benefits still offering HU to those with hereditary persistence of fetal hemoglobin who have pretty mild disease, in your opinion?
Yeah, I don't think it does. I mean, I think that patients with true SHPFH should be pretty much asymptomatic. So generally speaking, they shouldn't need any intervention at all.
Do you genotype and get the actual mutation to confirm, or are you just going based on?
No, this is with genotyping.
You do, okay.
And based on what's been in the literature. But so if there's any question, I would get a genotype, and we've actually sent samples to David Chewy in Boston, who has done a lot of analysis of suspected HPFH cases for us.
Oh, okay. That's helpful. And then you don't offer most of those?
So we have not offered hydroxyurea to patients with clear SHPFH.
Okay. I appreciate it. Thank you.
Mm-hmm.
Thank you. And then I think last question we have Laura Quill. Is she on the line? Just press *6 and you'll unmute your phone.
Yes, thank you. My question was, or just comment was that it looked like, again, subjectively, that you were more looking at the value that HU could play in these sickle cell homozygote patients versus have they yet had an acute chest or dactylitis. Am I correct in that thinking that is your subjective kind of point of view of whether they all should have HU offered?
Yes, at this point, that's correct. Obviously, most of the studies that have been performed to date have been on patients who were eligible because of having had frequent vaso-occlusive events.
Right. And just in your experience, have you treated any SC patients who've had, life-threatening acute chest or seem to have more pain?
Yes, we have. Actually, we reported that in pediatric blood and cancer, I think it was 2 years ago, but it was a combined experience from St. Jude and a hospital in Montreal, which happened to have a very similar experience. But I think we together had 15 cases of hemoglobin SC disease treated with hydroxyurea. We also attempted to treat it in a prospective study that was part of the Sickle Cell Comprehensive Centers Consortium, but that study was had to be discontinued before it was completed. But on the retrospective study involving our 2 institutions, we found that hydroxyurea decreased acute chest syndrome and pain similarly to, in SC patients, similarly to what it did in SS patients. That is, it roughly reduced it by 50%. And that toxicity was not a major factor. Again, it was mostly mild neutropenia, and this was, we had been concerned that possibly increasing hemoglobin levels might be potentially toxic in terms of their effect on blood flow rheology. But with limiting patients to hemoglobins no higher than 12.5 at the time of starting hydroxyurea, we did not find that anybody went up higher than 13. So that was not an issue as long as they didn't start from really high levels.
Okay.
And we also did not find that splenic hypertrophy was a concern,
okay.
Although theoretically that might be.
Thank you.
All right. I guess our time is up for this session. The next webinar will take place Thursday, November 7th from 2 to 3 p.m. Eastern Time, and it's titled Improved Survival of Children and Adolescents with Sickle Cell Disease by Dr. Charles Quinn of the Cincinnati Children's Hospital Medical Center. As a reminder, this is a special webinar session on the first Thursday of November. We will not have a webinar on the fourth Thursday of November, and there is no webinar scheduled for December. Please contact Shay Pope at spope@cdc.gov if you have any questions about this webinar series. The recorded webinars are made available at scinfo.org under the webinar toolbar. Thank you so much, Dr. Wang, and thank you for everyone for participating today. Have a great day.
You're very welcome. Thank you.